Good morning, everybody. So, this is on behalf of Ramesh Hospitals. Now I invite our junior colleague, a dynamic cardiologist, Dr. Raja Ramesh, to speak about the very interesting topic, very much interested to Indian population and doctors practicing in India. Dr. Raja Ramesh, over to you.
Yeah, thank you, sir. Good morning, everybody. So after an extensive session on pediatrics, so I would like to take you to the CAD in young patients. So respected dignitaries on the dais and my colleagues. So traditionally we thought of that CAD is a disease of the old age, but we are seeing nowadays since the last few decades, the CAD had moved into the young adults. So we are seeing that in the last few years that few celebrities having been died of the myocardial infarction. So there is an increased prevalence that CAD in young has increased. So we would like to start the discussion with a case example. So a 30 years male presented to the emergency with chest pain since 1 hour. So it is clear from the ECG that patient is having an ST elevation in the anterior leads and ST depression in the inferior leads, reciprocal changes. So this patient is having an extensive anterior wall MI, and it presented to us within window period. So this is the angiogram of the patient showing an LED lesion, and we have stented it. So the discussion is, the story ended here? No. So the questions before us, the big questions before us, could this young MI would have been prevented, and how to identify these high risk engaged apparently healthy individuals, and how to determine the presence of atherosclerosis in relatively asymptomatic young adults, and what is the role of primary prevention, and whether all young MI patients presented to us requires stenting.
Sir, any suggestions? And you are having heard about the case, young MI, so what can we do for this case? So
we could have modified some modifiable risk factors, such as the patient could have been, if he is a smoker, he should have been abstinent from smoking or alcohol.
Yeah, accepted, sir.
Yeah, and should be also be including some resistance training to increase the exercise tolerance to prevent and or definitely to minimize the stress levels.
Yes, sir. Yes. Yeah, we will move on to further discussion. So first, how to identify these risk young age individuals. So identifying young healthy individuals, relatively young adults who are at high risk for CAD remains a challenge, because the traditional risk scores like pool cohort studies, Framingham study, which calculates the ASCVD risk scores, they will give the score for only patient ranging from 40 to 75 years. So these scores will not include this young cohort. So difficult to find out who are at risk for CAD. These young patients. So we have to identify the risk enhancing factors in this group rather than calculating the risk. So what are these risk enhancing factors? So how to pick up the relatively young adults. So if there is any family history of premature atherosclerotic coronary vascular disease, if the patient from South Asian ethnicity, we know we are at a high risk for the development of coronary artery disease when compared to the Western population, and any patient with elevated biomarkers like elevated lipoprotein, or has told mentioned that active smoking is an important risk factor in young CAD patient. Are any comments on this one? Risk enhancing factors. So along with the traditional risk scores, these young patients will have to subject them for assessment of the polygenic risk scores, meaning that genome-wide association studies. These are the simplified scores that can assess the risk for CAD in young adults. As the traditional tools will not identify the young patients at a higher genetic risk for CAD, so the age alone is not sufficient to capture the lifetime risk at an individual level. So you have to look at the genetic level. So who are the young cohort that may develop CAD in the future? So especially chromosome 9p21 aberrations, it conferring a 25 to 30% increase in risk of CAD per allele. Like that, they are greater than 150 loci has been identified. Although this is not at practical, it is in the still research range. So in the future, we may develop the risk scores which involves the genetics. So what is the next step? So whether these genetic risk can be modified? Yes, as we are thinking, the genetic risk can be modified because the high PSR indicates high CAD risk despite the normal level of cholesterol and other traditional risk factors. So by initiating statins in these patients who are genetically risk at development of the CAD, we can modify this genetical risk. So along with the genetical risk, there is also a role for the measurement of inflammatory markers which have a prognostic value for future cardiovascular disease. So identifying apparently healthy individuals without known CAD who are at a high risk for the development of CAD with normal traditional risk factors. So we can alter the course of CAD in this young patient. So many such biomarkers have been identified, one of them being the high sensitivity C-reactive protein. So we have seen who are the patient at risk for this CAD and how to identify the risk enhancing factors. Now moving to the next step, how to determine the presence of atherosclerosis in an young adults who are apparently healthy. So would you like to discuss with the case scenario, a 43 years female is asymptomatic and a diabetic with a family history of coronary artery disease with the ECG and echo being normal. So how to proceed in this case, sir? Any comments?
Presence of diabetes in a family history. She is a diabetic and has family history of CAD. So she has two risk factors for coronary artery disease. So maybe she needs to be given advice about modified risk factors and started on statin therapy.
So before starting on statin therapy, would you like to further risk stratify her, sir?
Yeah, risk evaluation is important, and measure her blood pressure also. Her diastolic blood pressure is important.
Yeah, blood pressure is normal in these patients. So these are the lipid profile. The triglycerides are slightly on the higher side, and LDL is 40 and HDL is 39.
Presence of high triglycerides is an indication, is a very high risk factor for coronary artery disease in this case, along with the presence of family history of CAD.
So then how will you demonstrate the presence of atherosclerosis in this patient? We want to further investigate.
Calcium studies.
The calcium study. But before that, we want to do any stress testing like treadmill test.
Yes.
So actually, she is not able to perform the treadmill test because of the knee joint issues. So next step, stress testing. We have done the Ctca, as suggested, the coronary artery calcium score in this patient. So young female asymptomatic with two risk factors with borderline elevation in the triglycerides. So there is a calcium score of total 583, then LAD is 503 and RCA 80. So this high calcium score, we know anything greater than 400 is a high calcium score. So this indicates the importance of doing the Ctca in young patient with relatively low risk factors, but still the Ctca has a role. So use of coronary artery calcium score assessment by non-construct CT to refine risk satisfaction is important in the young adults. So the next question is whether Ctca can be done in young adults less than 40 years. The answer is yes, because studies shows that 10 to 34% of the young adults have calcium score greater than 0. So Ctca has a non-invasive strategy, provides a potential role to guide the preventive recommendations in young adults. So demonstration of atherosclerosis by Ctca has been associated with increased implementation of preventive strategies and starting the pharmacotherapies like statin and antiplatelets. So then we have risk stratified, we have demonstrated the atherosclerosis. Then what is the role of primary prevention? So primary prevention by meaning we have to break the cycle of coronary artery disease in young adults so that they will not develop the event like our case example, a 30 years male developing an MI. So we have to identify the patients in this green, yellow and orange, and we should stop them before entering into the red zone. So patient healthy but at risk for CAD, we have to identify by ethnicity or calculating the ASCVD risk scores, borderline risk scores, and demonstrating the subclinical CAD by coronary artery calcium score and calculating the lifetime risk scores. Already mentioned that many of the scores will give the 10 years risk, but this young adults we have to calculate the lifetime risk score. So any type 2 diabetes or uncontrolled hypertension and moderate hyperlipidemia, so we have to identify them and we have to target with primary prevention by statins, and we have to prevent before they entering into the ACS stage, that is where we have to give the secondary prevention. So along with traditional risk scores, we can also apply the polygenic risk scores and the latest bioinflammatory biomarkers. Coming to the last question, whether all young MI patient require stenting?
This is, I think, if we go as per the guidelines, we need to, it's the concept of in acute myocardial infarction thrombus is to remove the thrombus, and what we need to do is insulate the thrombus from the vascular lumen. So the initial part, some degree of thrombus aspiration can help, but my personal practice would always be to stent that rather than leaving that and putting these patients at a higher risk of recurrence of events which could be life-threatening.
Yeah, accepted, sir. So for initial aim is to stent, but if stenting is not feasible, if the patient has very high risk thrombus, we have other ways I am going to discuss in the next few slides. Because most of the young MI patients, especially in smokers, it is not the plaque rupture, it is the plaque erosion with high thrombus. So there are options of intracoronary thrombolysis, or as Sat mentioned, this thrombus aspiration can be done. Sometimes a simple balloon angioplasty can remove the, can push the thrombus. So would you like to show our study which we have conducted in our hospital? So we have included the young MI patient, age less than 40 years, presented with ST elevation myocardial infarction. So a total of 108 patients have been included. Especially the study was done during the pre-COVID pandemic time, June 22, May 2022. So we have 108 patients with the young MI presenting less than 40 years have been included, and we have studied the various risk factors and angiographic profile in these patients. So among the 108 patients, the 91 were males, the mean age is 35, and most common presentation being the anterior wall MI. And coming to the risk factors, the major risk factor we have found is the smokers, 83, that is 76.9% were smokers. And an angiography, most of them are having single vessel disease, with LAD being most commonly involved with high thrombus burden. So the mean age is 35 and most of them are male, and the risk factor distribution, smoking being the most common, present in 77%, that is 83 patients. The other traditional risk factors like diabetes and hypertension presenting around 20% each, and family history is positive in 14% of the patients.
Ramesh, shall we be fast?
Yeah. So this is the pattern of coronary artery distribution. LAD is commonly involved, and modes of treatment. Our initial aim is to stent. The PCA was done in 81 patients and POA was in 8 patients. So we would like to do 2-3 different cases. This is a young patient, 27, presented with an anterior wall MI. We have angiogram showing thrombus in the proximal LAD, and we have given an intracoronary thrombolysis with 1/3 dose of the traditional IV dose. What we are giving, we can see the completely recanalized LAD with the TIMI3 slow. So we have avoided stenting in this young patient. Similarly, this is a young patient presented during the COVID time, having a lot of thrombus. So we decided to aspirate the thrombus in this patient. We can see the thrombus aspiration catheter going inside and doing the job. So this is the post-thrombus aspiration. Sometimes we need an mechanical support in patient presenting with cardiogenic shock. So this is a young patient, 24, presented with an acute anterior wall MI showing thrombus in the left main and the LAD. So, and this cardiogenic shock was, we have put the IABP, and intracoronary thrombolysis was done, and after 15 minutes we have removed the IABP once the job was done, and the final we showing the TIMI3 flow, and we have avoided stenting in this patient. So there is a role for pre-hospital thrombolysis and intracoronary thrombolysis in STEMI patients. So in summary, there is a need to attempt to prevent young myocardial infarction in young myocardial infarctions. The traditional risk factors will not hold good for young patient. We have to search for the new strategies like polygenic risk score and calculating the inflammatory markers. So, calcium artery, coronary artery calcium score should be a part of routine evaluation in apparently individuals. Aggressive primary prevention may alter the course of CAD in young. There is a role of early intracoronary fibrinolysis may be considered if PCA is not possible in young patients. Thank you.
Thank you, Dr. Ramesh. This is a very important problem here. The CAD has changed dramatically for the last 4 decades. When I was a student, son used to bring father for a cardiac consultation. Now has changed. Father is bringing the son for consultation. So in young so can we predict? So what are your impression about this, Professor Rajsekhar?
No, as was mostly highlighted before, lifestyle like sedentary lifestyle, then junk food, obesity, then habits like smoking are very important. Of course, we cannot forget the genetic factors. The genetic factors also have to be kept in mind. So the only way is to go about screening the high-risk individuals. Among various tests that we have enumerated, I think even carotid intima media thickness may also be very useful.
Yes.
I think there's no radiation, and the only thing it requires a little bit of skill to elicit the carotid intima media thickness accurately. I think it can also be useful. And the other thing, when we have a myocardial infarction, whether in a young individual, whether we have to stent or not, I think nowadays the imaging guidelines are available. If there is plaque erosion on OCT, then the stent can be avoided. But if there is plaque rupture, then it is recommended to stent. Having said that, I will entirely agree with Dr. Kasturi that we are taking a risk. If you are not putting a stent, it is quite possible the same night the patient may close his artery, then you have some answerability issues, because no guidelines give class 1 for avoiding a stenting in a STEMI patient.
Accept, sir. Our first aim is to stunt it. If it large thrombus, then only we are thinking of the remaining options like intracoronary thrombolysis or aspiration.
Yes, Dr. Raghu said stent is needed in all patients. So my issue here is, especially in post-COVID state, is hypercoagulable state. It's like cocaine-like problem. So stent may attract more thrombus. So what is your impression, Professor Narasimhan?
I agree. The thing is, it may be a deferred stenting. Patient, you just take care of the thrombus first if you think it's predominantly a thrombus burden. But pre-discharge 48 hours prior, you recheck and then take a call what needs to be done. I think our understanding of the disease has improved significantly. We are able to have P-selectin, platelet activation and D-dimer. I think in 5 years our therapy for this will be individualized, depending on whether there is intense platelet activation in one, macrophage activation in the other, versus predominantly it's fibrin-rich clot. I think that is where the field is going towards precision medicine.
Thank you.
Thank you, sir.
Thank
Next
you, Ramesh.
speaker.
We'll go for the next speaker.
So coming to the next session, so this session we will be going to deal about the targets for lipids, diabetes and hypertension in various patients like with CAD or without CAD, and we have to, we'll mention a role of aspirin in the primary prevention of atherosclerotic vascular disease. So for this talk, I'm also involving our endocrinologist, Dr. Rakesh Boga. So again we are starting with the case scenario. So a 76 years female, diabetes hypertension since 15 years with the CAD, status post CABG in 2008, presented with class 4 dyspnea to the emergency. So an examination, pulse 100, BP 190, 100 and saturation 80% on room air, chest bilateral extensive crepitation. So this is the ECG showing an atrial flutter with a controlled ventricular rate. This arrhythmia she is having is quite a time with controlled heart rate with the drugs. So lab investigations, hemoglobin is 10.3, creat 1.5 and troponin 8.83. So echo is normal LV functions and it's moderate MR and moderate PAH. So I will like to ask, so how to proceed in the for the further session.
Sir,
So elderly female with post CABG presenting with class 4 dyspnea.
Starting her on in NTG drip is paramount in this case.
Yeah, accepted that we
Due to
have
the
done.
presence of pulmonary edema and high blood pressure. So followed by she might have be having LV failure also, secondary to hypertensive emergency. And following that, we have to assess the moderate MR and moderate PAH are there. So we have to assess the right heart function. So and along with the right heart function, we have to assess the lung volume also, because the presence of SOB and right heart failure with the presence of pulmonary edema, it begs to investigate the lungs also.
Accepted, sir. I will answer the second question. As she is a post-COVID recovery, 2 episodes of COVID and some interstitial lung disease is there. So our moderate PAH can be explained by that part. So do you want to evaluate, or do you think this is due to ischemic etiology or the hypertensive etiology, sir?
It looks like hypertensive etiology.
Yeah. So before saying that we have evaluated coronaries also, recently the Ctca was done for her for routine health checkup when she came, and grafts were normal. So as you told, this pulmonary edema is due to the accelerated hypertension. So as you told, she was started an IV anti-G and IV diuretics and mechanical ventilation with NIV. She was relieved from pulmonary edema in day 3 and slowly weaned off from NIV. But she is requiring multiple classes of hypertensive drugs to keep BP under control. So once again on day 4, similar episode requiring mechanical ventilation, and 4 such episodes each requiring ICU stay. And during the last episode, she was completely dependent on NIV and her creatinine starts increasing. The questions before us: why repeated episodes of pulmonary edema, sudden fluctuations in BP, why requiring multiple classes of drugs? Any comment? So we see it resistant hypertension, and what is the cause of resistant hypertension? So we should consider it as a resistant hypertension. She is requiring more than 3 drugs, including diuretics, and BP is still greater than 140/90, requiring NIV whenever she is landing in heart failure. So we have to consider in resistant hypertension screening for patient with secondary hypertension. So among the secondary hypertension, the most common cause being the renal parenchymal disease and the renovascular hypertension. So we have done a Doppler in her, which is showing increased gradients across the left renal artery. Then we went ahead with the renal angiogram, showing the stenosis at the origin of the left renal artery, around 90% stenosis with the calcified. So we decided to stent, and we have stented the patient. So this is evidence that is renal artery stenting the current treatment. Although the randomized trial shows that there is no mortality benefit between the medical treatment and stenting in the renal artery stenosis, small studies show that after the stenting, the medications for hypertension for hypertension control can be come down, and some randomized trials even shows mortality benefit. So post stenting, the frequency of accelerated hypertension came down significantly, and renal parameters improved. And since last 1 year, there are no further episodes of pulmonary edema, and the doses of hypertensive drugs we are able to come down.
Sir, should we stop, Ramesh, and we'll go, because there is a lot of time constraint.
Okay. Sure, ma'am.
Only 20 minutes more for this session.
Yeah.
Yeah.
We want to discuss.
Yes. We just stop this and we'll go to next topic.
Yeah. So this just went to suspect renal artery stenosis, severe hypertension refractory to therapy, like in our case, recurrent episodes of pulmonary edema, abrupt onset of hypertension. And these are the 2 other patients we have stented the last month with the similar case scenarios. So then I would like to call Rakesh Bubba also to join with me so that we can discuss the case. So we would like to discuss the hypertension, diabetes, and lipid goals with the case scenarios. The first case scenario: a young age male, 35 years, came for routine checkup, found to have new onset diabetes, the LDL being 120, HbA1c 7.7, and BMI of 24, and blood pressure of 140/90, and there is no any family history of premature coronary artery disease. The first question being, does this patient require statin therapy?
According to ATP 4 guidelines, a person's age more than 35, more than or equal to 35 plus high LDL requires statin therapy.
Sir, high LDL means how much high it should be, sir? It is enough, this 120 is enough to start the statin therapy?
More than 140 I think is the given in guidelines.
Okay, sir. So accepted. So this patient has such may not require, but as sir mentioned, if the LDL is greater than 160 and if there is any family history of premature coronary vascular disease or any risk enhancing factors like primary hyperlipidemia, smoking, CKD, any inflammatory conditions. So these are the subset of patient, even though they are young, they require the statin therapy. So I would like to ask our endocrinologist, what are the ideal anti-diabetic agents in this patient?
So this patient is a newly detected diabetic with HbA1c of 7.7% with a high LDL and no other clear atherosclerotic cardiovascular risk factors. Nowadays we have many classes of oral anti-diabetic agents available for the treatment of diabetes like sulfonylureas, metformin, SGLT2 inhibitors, GLP-1 receptor agonists. So among all these classes, still guidelines prefer lifestyle intervention and metformin as the first line therapy. But we have to look at the presence of other indications like do we need weight loss or we need to prevent weight gain in this patient, what is his blood pressure, do we need a blood pressure reduction and any hypoglycemia risk and any family history of atherosclerotic cardiovascular disease. So looking into all these factors, starting a metformin and SGLT2 inhibitor combination would be good so that it can achieve a weight loss. Patient has a BMI of 24 which is a overweight category in Asian Indians. And it can also lead to a small reduction in the blood pressure.
Any comments?
Thank you. This is to our moderators. So we want to give a precise advice to our practitioners. Diabetes is a CAD equivalent. The idea of treating statins in a diabetic patient is reduced to LDL to less than 100. That is the recommendations. What is your advice, Dr. Raghu?
Okay, so the LDL cutoff should be very clear cut. Previously, we used to start therapy based upon LDL. Nowadays, we do not choose the therapy based upon LDL only. It is a multiple risk factors we need to assess. Well, for example, this gentleman, even though he is young, he has got hypertension, he has got borderline obesity, and he has got diabetes. So he is a potential candidate for lipid lowering. That's number one. Having said that, Dr. Bhaskar Naidu has brought one more thing is the target of the LDL. The target of the LDL is less than 100 for a diabetic, less than 70 for a coronary artery disease patient, but who is a high risk coronary artery disease patient, we go to less than 55. So our target should be clear in the physician's mind. It is not the dose of the statin what you choose, but what is the level of the LDL what you are targeting. That is what you need to look in your mind or keep in your mind when you start these patients on therapy.
For this patient you want to target below 100, sir?
Yes.
Yeah, that is a very clear, precise message. Thank you.
Yeah, one more quick point is, for this gentleman, he is only 35 years. It is not the point of LDL on that day. It is a cumulative LDL burden which happens over his lifetime that is more important rather than the LDL on that day.
Yes.
So I would have a lower threshold to start him on a lipid lowering.
Yes. Accept.
Thank you.
So, Sash, next question being, should we start antihypertensives in this patient? Well.
As the patient already requires lifestyle modifications, as he has diabetes, maybe we can monitor his pre-hypertension status over a period of 3 months, then put him on DASH diet, then see how his BP is.
Yeah, exactly. This 140/91 reading, we would like to reconfirm, take the 2 or 3 readings. If still persistently high on the lifestyle modifications, then we would like to start the antihypertensive drugs. So what is an ideal antihypertensive drug for this patient if you want to start?
ARBs.
Accepted. Young patient with diabetes, so the first choice will be ARBs and ACE inhibitors. Good. Now the last question and important question, whether there is any role of aspirin in this patient. 35 years, diabetic, asymptomatic, borderline LDL, obesity, overweight and borderline BP, that this patient require aspirin. Sir wants.
No, as of now, I don't advise, because we are seeing actually gastric intolerance and bleeding tendencies also more. We will wait and see. With the disease modification or actually this lifestyle modification, if doesn't BP come down and if the lipid lowering is not satisfiable, then you have to go for it.
Accepted, sir. A young patient less than 50 years of age with low atherosclerotic vascular disease, there is no role for aspirin. If the patient has an intermediate risk, then discussion should be done regarding the benefits of the bleeding and ischemic events, then we have to proceed. So then we will move on to the second case scenario, a 45 years old male.
Ramesh? Okay, we'll go to the next case.
This is next case only, sir.
Next discussion. Enough. Okay? Right. So, thank you. So, in this case, the idea of starting statin is to aim at LDL less than 100, preferably ARB or ACE inhibitor for antihypertension drug. Role of aspirin, as our colleague said, is still controversial. So, we may not start it, but anyway, two great studies, Physics Health Study and Nurse said, danger in starting aspirin without proved CAD. Thank you so much. Our next speaker, Dr. Kumar Velgaru.
Yeah, a neurologist standing in an ocean of cardiology.
Thank you.
I don't know how I sailed through. Let's see over the next 6 minutes. A 69 years old male, non-hypertensive and diabetic, presented with angina, breathlessness on exertion and sweating on 24th of last month. Diagnosed as anterior wall MI and thrombolized in the nearby hospital with streptokinase, non-invasive ventilation for LV failure, an angio done on 23rd of last month revealed a significant LAD disease for which an ad hoc PCI was done. The story doesn't end here. On 29, 6 days after his PCI, he develops acute right hemiparesis at 14:30 hours in the ward. As you can see here, there is an acute infarct in the left middle cerebral artery territory with a normal vasculature. What shall we do? If anybody would like to volunteer, otherwise for want of time, I'll go further.
We should rule out acute stent thrombosis which leads to cardioembolic stroke first. So again, we have to do coronary angiogram to see the stent patency.
But unfortunately, the brain will not wait. You got to act somewhere, isn't it? So what we did was, we thrombolized this patient with injection tenecteplase, 17.5 milligrams, 0.25 milligram per kg, as per this thing, as the international standards, IV bolus. Patient, the neurological status improved, but his cardiac status was worsening because of the underlying coronary artery disease. So our point is concomitant coronary and carotid atherosclerosis. The incidence is significant, where you can see the significant carotid artery disease is seen in 12.85% of patients, with severe carotid artery stenosis seen in about 5% of patients, mild carotid disease in 58%. A total of around 70% of patients have got concomitant carotid disease and vice versa. So the independent predictors of severe carotid artery stenosis or total internal carotid occlusion could be as a presence of left main disease or triple vessel disease, increasing age, history of stroke in the past, smoking status, type 2 diabetes mellitus. The progression of carotid artery stenosis on sequential Doppler studies has been shown to be a stronger correlate of future myocardial infarction events than of stroke. The presence of carotid artery stenosis has been shown in multiple studies to increase the risk of perioperative stroke in patients undergoing CABG, which my Dr. Jayaram Pai will vouch for when we had some patients had the problem. Presence of coronary artery disease increases the risk of peripheral vascular surgery, including carotid endarterectomy. Now, how do we diagnose carotid stenosis? Extracranial by ultrasound duplex scan, Intracranial, why do we look for intracranial stenosis is important is, as per Wadla and his group, 42% was the incidence of intracranial carotid disease, whereas in Indian patients it is 78% as per the Hyderabad registry. So how do we diagnose? The methodology available are invasive angiogram, magnetic resonance angiogram with or without contrast, CT angiogram with contrast, and a transcranial Doppler. This is the Doppler machine, which is simple, available, where it can be done within this thing, non-invasive, bedside, accurate and real time. As you can see in this thing, we have got a power mode where you can see the flow on top, the one which is shown in green. I don't know which is the pointer. The green one means, the red one means the flow is towards the probe, and the blue one means the flow is away from the probe, and the below one is the M mode where you can see the normal TCD flow, where you can see the systolic peak is vertical with the diastolic going down gradually down to this thing with a peak of 107 and an end diastolic velocity of 44.2. Whereas in a patient with ischemic cerebrovascular disease, where you can see is that there is a significant, as you can see in the slide, I don't know the marker. Yeah. As you can see there is a laminar flow, there is nothing. Whereas where you can see here, when there is a turbulent flow, there is a Venturi effect where you can see, and that is what is contributed here by this diastolic turbulence. As you can see that when there is a 50% stenosis on TCD, where you can see that there is a blunted upslope of the systolic peak with a gradual but a sustained end diastolic velocity being higher than normal. As the stenosis keeps on increasing, where you can see the mean flow velocity crosses 100 meters per second. That means it is significant of beyond 100 is considered as significant in mean flow velocity, systolic velocity, and when there is more than 70% stenosis, you can see some turbulence, and that is what is equivalent of a bruit over the vessel. Now, what is the specificity and sensitivity of intracranial atherosclerotic disease? CT angiogram is the gold standard as of now, upon next to invasive angiogram, where equivalent is 0.99 per 9. MR angiography non-contrast is 0.82 sensitive and 0.95 specificity, and TCD rates very close to the CT angiogram, 0.95 each, with a positive predictive value of 93% and a negative predictive value of 96%. This is as per a recent meta-analysis. So in conclusion, concomitant carotid atherosclerotic disease, both extra and intracranial, need to be evaluated and treated while treating acute coronary syndrome. Extracranial carotid evaluation is by carotid ultrasound, whereas an intracranial evaluation is done by a transcranial Doppler, where it is administered by professionals with adequate experience and skills, can provide useful diagnostic information for detecting stenosis or occlusion of intracranial vessels in people with acute ischemic stroke, or guide the request for more invasive vascular neuroimaging. So let not our patients of carotid intervention land up with a carotid stroke and land up with such a thing. Let them have a beautiful roadmap ahead. Thank you.
Thank you, Dr. Kumaravelu. So to moderate this topic, so combination of cerebrovascular, cardiovascular events is very difficult for the physician to convince the patient attenders. Transcranial Doppler, it needs expertise and precision. So such cases, what is your plan of treatment at SWIMS, Professor Rajsekhar?
Many times we see patients who have combined both myocardial infarction as well as the stroke. So we can, first of all, we should remember that plaque inflammation is a systemic process, and therefore erosions could occur in plaques in multiple sites. That could explain the occurrence of both this myocardial infarction and stroke. But other things which we have to keep in mind is like In some of the studies, it has been shown that if we are doing thrombus aspiration while doing the percutaneous intervention, there is a higher incidence of stroke during the 1 month period after the procedure. So that also we should keep in mind whether, otherwise also there could be some clots in the aorta, so when we are doing intervention, there could be some microemboli which could have produced a stroke. And of course, one of the panelists said that maybe there is stent thrombosis. And you also said that this patient worsened cardiac status wise. Maybe there is a stent thrombosis and occurrence of LV thrombus which embolizes. So these are the various possibilities. One is thrombus from the left ventricle, other one is the procedure dislodging some plaques from the aorta, and the third one is thrombus aspiration could lead to some embolization. And we should not forget this plaque inflammation is a systemic disease, and therefore many plaques in the body could have ruptured along at the same time.
Okay, thank you. Now I invite our next speaker, Dr. Srikar.
Good morning, everybody. I'll be discussing on peripheral arterial disease and coronary artery disease interrelation. Basically, these both diseases are two sides of the same coin. The reason being their etiology, their pathophysiology, the clinical presentation, the risk factors, and the treatment strategies are almost similar to both these kinds of diseases. Even though we use the term peripheral arterial disease and peripheral vascular disease interchangeably, the term peripheral arterial disease is reserved to the atherosclerotic disease involving the blood vessels in the form of in the various vascular territories. You can have a carotid artery stenosis, a renal artery stenosis, the visceral artery stenosis. So these are all categorized under peripheral arterial diseases. And if you look at the occurrence of coronary artery disease in a peripheral vascular patient, the incidence reported across studies is as high as 50 to 70%. In the initial in the initial stages of peripheral arterial disease, we go with medical management. As the disease advances, patients will require endovascular and open surgical procedures. So let us get across various territories into the body where we see peripheral arterial diseases and how do we manage them. So basically, this is a patient who presented with recurrent transient ischemic attacks. What you're seeing here is an distal subtraction angiogram centered upon the neck. The lateral view, the catheter is located within the common carotid artery, and what you're seeing, it is getting branched into the external and the internal carotid arteries. Over the internal carotid artery, you can see there is a severe significant stenotic lesion. So, sir, what are the indications for carotid artery stenting, sir? Indications for carotid artery stenting. Do you stent every single carotid artery patient? So basically, we do carotid artery stentings only in symptomatic patients. Symptomatic patients with more than 50 to 70% luminal narrowing will require endovascular intervention, and asymptomatic patient with more than 80% lesions will require endovascular strategies and management. The image on the right, what you're seeing, this is a roadmap image. Using this image, you can see how we are able to cross across the lesion into the internal carotid artery, and followed by the placement of a wall stent within it. This is the post-stenting angiogram in which you are seeing there is a nice free flow across the stent into the internal carotid artery. Moving on to the subclavian territory, the subclavian artery very commonly undergoes stenosis at the location where it takes off from the aorta, which is the aortic ostium. So these patients present in three ways. The three ways in which they present are: one, either with limb complaints in the form of heaviness, fatigue, or numbness along the pulp of the fingers, discoloration. This is one way in which they present. The other two ways by which they can present are, because of the presence of stenosis at the level of the ostium, the vertebral artery, there will be flow reversal in the vertebral artery. Because of the presence of flow reversal in the vertebral artery, patients can have posterior circulation transient ischemic attacks. That is the second way of presentation. The third way is somebody who has got an LAD to a Lima graft. So obviously if there is a stenosis at the level of the ostium, these patients, because of the coronary steal which is happening, they can have a myocardial ischemia. See, if you look at this particular patient, this is an angiogram which is centered upon the head and neck vessels. You can see the catheter tip which is located in the subclavian artery in the right side, and there is free flow of contrast into the cerebral circulation. This is the right vertebral artery, and there is flow reversal in the left vertebral artery which is flowing down and which is feeding the subclavian artery of the left side. So this is what we call a vertebral steal. So this patient underwent an endovascular revascularization strategy. So this is a coronal CT image which is showing the totally occluded subclavian ostium, and this is post angioplasty and stenting. You can see there is a nice free flow of contrast into the left intramammary artery and also into the left vertebral artery. Moving on to abdominal aortic aneurysms. We all know aneurysms occur because of the focal weakness in the wall of the aorta. They keep expanding, and the risk of rupture of the sac becomes very high when the diameter of the aneurysm becomes more than 5 centimeters. So we do have a special device. We do have a special implant in this set of patients. What we call is a stent graft. The difference between a regular stent and a stent graft is the regular stent is, we call it a bare stent because it doesn't have any covering, while a stent graft, it has got a covering which is coated with either PTFE or there are various other synthetic materials which are used to coat this particular graft. So this when it is placed into the aorta, we place it in such a way that both ends of the graft are in the healthier segments. So obviously what happens is we are creating a tight seal between the graft and the aorta so that there is no free flow of contrast between the stent and obviously between the aorta. So this is a conduit what you can create in an endovascular means. This is one of the best methods by which you can treat abdominal aortic aneurysms. So if you look at this particular patient had an abdominal aortic aneurysm just above the level of the celiac artery. This is a lateral projection distal subtraction angiogram. So this is what you're seeing on the right side is the post procedure, post graft placement in the abdominal aorta. You can see the aneurysm is no longer filling. So the aorta, it undergoes a remodeling in that particular location. Obviously the sac doesn't get filled, thereby you can prevent the catastrophic rupture happening in this set of patients. Moving on to renal artery stenosis patients. So the only the indications for renal artery interventions include one, either a patient who has got refractory hypertension, he is already on 3 different types of antihypertensive drugs including diuretics, and still his hypertension is not responding. The second set of patients in whom you don't have any particular explanation and the patient's RFTs are deteriorating. So these are the set of patients who will require a renal artery intervention. Not every stenotic lesion will not require a treatment. So the primary investigation, obviously you do get a suspicion of renal artery stenosis on a Doppler. So this is a Doppler of a renal artery. You can see that there is a Tardas Parvus waveform which indicates that the flow velocity, the flow velocities are very low, and also you don't see a typical triphasic pattern what you ideally see in the renal artery. So obviously this is an iotogram which we did in a cath lab. You can see this patient has got bilateral ostial narrowing of the renal arteries, and this is you can see already we have landed a stent in the right renal artery, and this is a balloon expandable stent what is going into the left renal artery. So moving on to celiac artery territory, obviously the celiac artery can undergo different types of narrowings very close to its ostium. The 2 main causes are intraluminal and extraluminal. The intraluminal causes include atherosclerotic disease, and the extraluminal causes include median arcuate ligament syndrome, wherein the median arcuate ligament, which is a part of the diaphragm, when the patient takes a deep breath, the celiac artery gets trapped in between the aorta and the median arcuate ligament. If you look at this is a coronal reconstructed CT angiographic image, you can see there is a tight stenosis very close to the ostium of the celiac artery. So because of the stenotic location, you can see this particular vessel. This is the arcade which is formed between the celiac artery and the SMA, which is the pancreaticoduodenal arcade. So obviously the gastroduodenal artery, this is the gastroduodenal artery which is coming and anastomosing with a branch of the superior mesenteric artery. This is the gastroduodenal arcade. Obviously body tries to compensate this particular loss. So never stent a patient who has got a median arcuate ligament syndrome. It is only catastrophic. Moving on to superior mesenteric artery patients, these patients very commonly present with postprandial significant pain after having food actually. So this patient presented to us and obviously this is a lateral SMA angiogram. You can see a right stenosis lesion very close to the ostium of the lesion. This is post-stenting angiogram. You can see there is a nice free flow of contrast across it. These are two images which are 2 years apart. Both of them are sagittal images. Very clearly you can see, look at the visceral fat in this particular area and look at the visceral fat in this particular area, even the subcutaneous fat. So this, and also you can look at the cute looking stent which is placed in the SMA. So 2 years follow-up, initially because of weight loss, this is how the patient looked, and this is after the patient has gained good amount of weight. So moving to the lower extremity territories, I would just finish in last 2 minutes, sir. So obviously the lower extremity territories, this is a patient who has got a significant gangrene which was involving the great toe actually. You can see this is a distal angiogram, subtraction angiogram. There is total occlusion of the SFA and there are multiple collaterals which are coming and feeding the lower popliteal artery. From the popliteal artery onwards, you can see that there is a 2-vessel runoff to the foot in the form of posterior tibial and peroneal arteries. So we have subjected this patient, we are just trying to cross that particular lesion. This is a near total occlusion chronic CTO which was involving the ostium of the SFA. What you are seeing, the other vessel here, this is the profunda artery. So once we have crossed it, obviously we are trying to balloon it. It did respond very well to balloon angioplasty, and this is the final result what you are seeing. So we do lots of interventions in the below-knee vessels as well, which include the popliteal artery and also the tibials actually. So obviously if you look at this particular, this is a pre-procedure angiogram. You can see there are multifocal stenotic lesions which are involving the anterior tibial artery. Also you can see that there are multifocal stenotic lesions in the posterior tibial artery, as well as in the lower part there is no filling, it is totally occluded. This is post angioplasty. You can see that the artery has opened very well, and if you look at the images of the foot, this is before the procedure and this is after the procedure. You can see there is a dominant peroneal which is feeding both the anterior and posterior tibial arteries, but after endovascular revascularization, you can see there is direct inline flow to this particular set of vessels. So to conclude, obviously most of the patients with peripheral arterial disease, 50 to 70% of the peripheral arterial disease patients almost always have a coronary artery disease, but the vice versa, coronary artery disease patients having peripheral arterial disease is close to 10 to 20%. Thank you.
Thank you, Srikar. Peripheral vascular disease is very common. Association of CVD and CVA with PVD is common. They are no longer die of gangrene, but the outcome is different. Non-coronary interventions are gaining momentum. So what is, to moderate this, what is the message you give to the practicing physician, Mr. Raghu?
The scenario what Dr. Srikar was telling are quite common in our daily work, but what we need to understand is most of these diseases, especially in the peripheral vascular terrain and the renal vascular terrain, happen about a decade or a 1.5 decade after we intervene on the coronaries. So if we continue to have a very good secondary prevention strategies, we might be able to minimize the burden of the vascular disease in the other territories.
Yeah, this is pan-atherosclerotic disease we saw from head to foot. So if you don't aggressively modify the risk factors, they'll come with a occlusion in a different territory. So you may fix a tibial, they'll come with a stroke. You do something in the celiac, they'll come with progressive renal artery stenosis. So this is number one, generalized. Second thing, increasingly we realize is these are patients who come back with cognitive decline and Alzheimer's. So if you don't modify the risk factors and you think that your lesion-centric approach, most of these patients over a few years will come with cognitive decline, increasing malignancies, and so on and so forth. This is a lifestyle disease and we need to aggressively correct it.
Thank you so much. So next our speaker, I invite Dr. Balakrishna. So topic is very much interesting. Sleep apnea without CAD. Over to you. Balakrishna, be brief. We have a time constraint.
As a restraint of time, I'll complete first within 10 minutes and all. My topic is about obstructive sleep apnea and metabolic disease and CAD and non-CAD diseases. Coming a case study, a 38-year-old male patient with complaints of shortness of breath and chest discomfort. He has gained weight of 20 kg for 9 months and has no cough or sputum production. And he has acanthosis nigrans in both the neck, and rest of the general and systemic examination are normal. He has past medical history of hypertension, type 2 diabetes, hyperlipidemia, and is an ex-smoker and is a bank executive having a sedentary lifestyle. Further test revealed that he has fasting blood sugar high, HbA1c was 8.46, and triglycerides are high, and LDL are high, and low HDL cholesterol, and he has persistently high blood pressures, and serum creatine or electrolytes are normal. And his wife complains of that he is doing as dozy off in front of while watching TV or reading newspaper, and he has a daytime sleepiness. And he also admits that he fall asleep during meetings. And this is a ECG. It shows TV inversions and normal chestography, and ABG specifically shows that PCO2 was elevated by 63.2. So it may present with type 2 respiratory failure. And as a physician, what may be the differential diagnosis for these patients, and what are the important components of good sleeping? Mike.
These are the possible diagnoses. If there may be more than one diagnosis here.
Yes. Definitely, I agree, sir. As sir said, is more in favor of COPD and acute severe asthma and obstructive sleep apnea and any restrictive lung diseases, kyphoscoliosis and morbid obesity and other neuromuscular diseases. And according to sleep components, the sleep duration must be at least 7 to 9 hours, and there will be no much awakenings in the sleep. And sleep quality must be good. And sleep latency, the onset of sleep after going to bed must at least be below 20 minutes. And the sleep efficiency on the bed time must be more than 85%. Coming to examination, he has high Mallampati score was 3 and high arch palate and neck size was 7.5 centimeters. Based on that, we conclude that patient was having obstructive sleep apnea. It is a sleep-related breathing disorder that involves decrease a complete airway, halt in airflow despite of ongoing effort to breathe. It occurs when the muscles relax during sleep and causing soft tissues in the back of the throat to collapse and block the upper airways. And in physical examination, they usually have obese and large neck, 42 centimeters in men and more than 32 centimeters in women. And the other has another anatomical abnormalities. And next part is what are the symptoms of OSA and what are the risk factors of obstructive sleep apnea. Usually they have daytime symptoms and nighttime symptoms. The daytime symptoms they present with early morning headaches, daytime sleepiness and poor concentration. Night they have persistent snoring and wheezes, choking, gasping and restless sleep. And the risk factors coming to structural abnormalities, any anatomical abnormalities like retinoganthia, microganthia and mandibular hypoplasia in adults, whereas in pediatric population in adenotonsillar hypertrophy they are present with OSA. And non-structural risk factors are mostly obesity, central fat distribution, and alcohol use and sedative use. And what are the other parts of thing is, what are the differential diagnosis of daytime hypersomnolence or daytime sleepiness, and how we measure it. These are the different types of acute daytime sleepiness. The first was insufficient sleep. Next part is any medical psychiatric disorders, and others is any drug abuse. And coming to sleep disorders, they might have obstructive sleep apnea, central sleep apnea, and other parasomnias like restless leg syndrome, periodic leg movement disorders and all. Another thing is obesity, hyperventilation. These are the various differential DDs for daytime sleepiness. And now coming to scoring, how we would score the patient. These are the different scores for sleep apnea. The stop bank questionnaire. These are the different points to address it for scoring and all. And Epworth sleepiness scale, it helps the patients who to screen the drivers and all, who assess their sleepiness and all. And here in this patient, his Epworth sleep score was 12 out of 24, and stop bank questionnaire was 7, which is high risk. And how we diagnose OSA, and what are the what is the available diagnosis of OSA? What are the guidelines for it? Polysomnography is the gold standard for assessing the sleep OSA, and different parameters are present. The level 1 has 7 channels like measures EEG, brainwaves, EOG, muscular movements, EMG, airflow, respiratory effort, oxygen saturation, and ECG. Level 4, level 3 and 4 usually do the home studies, which has only 3 to 4 channels. And there are different types of how you classify the severity of sleep apnea and what is apnea and hypopnea index. These are the different. If there is a apnea hypopnea index, we calculate by apneas plus hypopneas. Apnea is less arrest of breathing, hypopnea is lower breathing by total sleep time by hours. And if it is less than 5 is normal, if the 5 to 15 is mild and 15 to 30 is moderate and above 30 is severe. These are the usual how the sleep studies shows. And we decided he has a high risk of this a sleep study was done, and these are the different parameters. We have done sleep study about 8 hours. Sleep latency was 10 minutes only, 10 minutes, and sleep time was around 400 minutes. And this person has a 295 respiratory events consisting of 35 obstructive apneas and 22 mixed apneas and 0 central apneas. And he observed that pulse ox saturation was average was 94, and he was pulsating between 86 to 99%. And then this is a slide which shows how we differentiate between different types of sleep apneas. The obstructive sleep apnea and the central sleep apnea. In obstructive sleep apnea, the airflow may not present, but there is a thoracic movement and there is a desaturation. Whereas in central sleep apnea, the airflow will is not present, there is no thoracic movement also. This is how we differentiate between obstructive sleep apnea. This is a mixed thing is, there is no airflow and there is no thoracic movement and desaturation, and my upper airway application may present or not present, or attempts to breathe may present or not present in mixed apneas. This is the usual sleep studies shows. Based on this polysomnography, we recommend a treatment. What the treatment modalities for the sleep study are: for the surgical part, we advise on weight loss, avoidance of alcohol, sedatives, and surgical part we do uropelotopharyngoplasty to open the airways. And at the non-surgical part, we advise the BiPAP. I usually advise NAV support, which was CPAP and BiPAP. BiPAP is more comfortable in sleep apnea patients because the inspiration has high pressures and when a patient is able to expel, he has a low pressures. And what are the OS associated diseases and what is the mechanism? Usually is associated various types of diseases like cerebrovascular stroke, headaches, and coronary artery disease, hypertension, and various cardiac arrhythmias and other things. This usually to hypoxia and reoxygenation, there is a oxidative stress and causes systemic inflammation. Then there is an endothelial injury over there and lead to atherosclerosis in the coronary arteries, leading to cardiovascular diseases. And also persons we have the insulin resistance and develop type 2 diabetes.
Should be.
And if you find that the patient with the OSA has a fitting into last type. If he was fitting into the metabolic syndrome, I can ask them what is the criteria for metabolic syndrome.
Waist circumference more than or equal to 1 or 2 centimeters in men and more than or equal to 88 centimeters in women. Presence of hypertension, insulin resistance or diabetes mellitus.
The one question I want to ask before concluding: is it an inflammatory disorder? This question.
Sir.
Is it an inflammatory disorder?
Yes, sir. In obesity and general obesity is and OSA also. There is what you call the oxidation and reoxidation. There is a systemic inflammation, sir. The elevation of reotoxin species and causing inflammation, leading to different endothelial dysfunction and causing coronary artery.
Because my point is whether the metabolic syndrome is a result of the OSA, the part of the OSA. It could be part of OSA. It need not be resulting. Okay. So we have done a lot of research into anti-inflammatory drugs where they are useful in preventing the OSA as well as metabolic disorder. That has to look into too. Okay. Because latest study shows the inflammatory disorder, the inflammation present around the outlet and inlet of the. Okay. So that has to be clear into. Because there are no pharmacotherapy as done for the OSA. So only thing mechanical support, the face mask or the CPAP or BiPAP.
Yes.
And surgery also is of limited value.
Yes.
Most of the patients who underwent surgery are landing in CPAP ultimately. So we have to look forward into any pharmacological intervention. That's my sincere request.
Okay, sir. Thank you, sir.
Yeah, this is an important cause of unexplained PVC, ventricular arrhythmia and atrial fibrillation. So it's important to screen this. And second thing is this misconception patient should be obese doesn't apply to a lot of patients with heart failure. In patients with heart failure, they have significant muscle wasting and they will have sleep apnea despite having a normal BMI. And the third is an important question that was brought out. When you unload these respiratory muscles with BiPAP and CPAP, over a period of time they develop atrophy of these muscles. So an important component of sleep apnea is to train these respiratory palatal muscles, tongue muscle movement so that the tone improves. So if you don't do that and mechanically keep prescribing CPAP, it may work transiently but there will be progressive atrophy of these muscles. So inspiratory resistance training with an inspirator is a very, very useful measure to increase the tone of these muscles.
Thank you so much.
With this, we will conclude this session. I request Bhaskar Naidu sir to honor the panelists and moderators with mementos.